I'm Dr. Phil Clements, professor at UCLA forever. I've been taking care of people with scleroderma for 42 years. And the talk that I'm going to give is based upon my interviews with people over 40 years. I'm not going to cover all the questions they ask, but I'm going to try and address some of the questions, the important ones. So the first question is, do I have scleroderma? Now, some of you probably already know that. Some people who come to see me aren't sure yet, so we'll talk about that. When did it begin? That's more important to me to get an understanding of where these folks are in their disease, and I can give them some advice about what things we need to do for the future and manage things. Then they want to know whether their skin thickening will ever go away. And what involvements do I have of heart, lung, kidney, GI tract? And what are the probabilities that I will develop these kind of problems over time? So before I really get into do I have scleroderma, there are a couple of factoids. 95% of people with scleroderma have tight skin on the middle of the top of the finger. So there's a knuckle, skin, knuckle, and right there in the middle, normally you should be able to pick up the skin. In people with scleroderma, sometimes very difficult. Yeah, getting one head nod. 90% of people with scleroderma have Raynaud's phenomenon. For those of you that have it, I don't need to explain it. And 95% are ANA positive. ANA is not a diagnostic tool. It's a screening tool. In the broadest sense, it says, look at me and see if I have an autoimmune disease. Well, scleroderma is an autoimmune disease, and ANA is positive 95% of the time. The pattern that you see here actually is a specific to scleroderma pattern called centromere. I'll get back to that a little later. So the general rule is that if the skin of the fingers is not tight and the ANA is negative and there's no history of Raynaud's, there's no systemic sclerosis. So that's a quick screen. Walk in the door and ask a few questions, and if it's not scleroderma, then we need to start thinking of other things. About 40+% of us around the world got together in a study to revise the classification criteria for diagnosing systemic sclerosis. They are much better than the 1980 criteria, so I'm going to walk you through them. The surest way is to examine the fingers and examine skin and other parts of the body, and if they have fingers tight and thickness anywhere else, that's scleroderma. So it could be the face, forearm, back of the hand, torso. Tight skin on the fingers plus any of those others means that you probably have scleroderma. Now that means about 25 or 30% don't quite fit into the criteria, that particular criteria. So the difference between the 1980 and the 2013 is we've included criteria or sub-criteria that allow us to make a bigger net to catch people that have scleroderma. So they're weighted scales, and I'm going to show you pictures of these. Skin thickening, sores on the skin, telangiectasias, abnormal Nailfold capillaries, presence of pulmonary hypertension or fibrosis of the lung, Raynaud's, and scleroderma-specific antibodies, in particular anti-centromere, anti-SCL70, and anti-RNA polymerase. So now we'll start with the top one. So on the left hand, there is a person with a puffy-looking hand. This is a Hispanic American female that I took care of 30-some years ago. And this was her first presentation, puffy fingers that looked like that. The right hand was a man I took care of for 5 or 10 years who had really solidly gotten hard skin. The skin on his fingers and the back of his hand was very thick and tough. So either of those counts. The left upper hand, I don't know whether you can see it real well, but there are a couple of little divots in the fingertips. They are probably leftover scars from not enough blood getting to the fingertips. So they're left divots in the skin. They're no longer tender. They're not active. They're kind of scars. In the lower left, you see somebody that's got healing or partially scabbed fingertips. They're probably still sore. The right hand panels, both of those folks really have painful digits. Telangiectasias are collections of little tiny blood vessels in the skin. They most likely occur on the face, here, the lips, the tongue, and the hand. You can see them in other places, but these are the most typical places. When you run your hand over it, it's smooth. They're not raised bumps. And if you push on them, they turn skin-colored, and then when you let off, blood flows back in and they turn red. Usually they're harmless. The Nailfold capillaroscopy is a technique that has been around a long time, but it's only received prominence probably in the last 10 years. And it's a good technique. You can spend $20,000 on an apparatus to find these, or you can spend $12.50 and get something that will do pretty well. So what I've done to the finger is put a little goo around the cuticle and the skin around there, and then have a light source and a 10-power microscope eyepiece, which I stole 20 years ago from somewhere. You can use other things, or the doc can. The jeweler's loop, I'm told by a jeweler friend or patient of mine that we ought to be spending $25 to get a lens that really works. Dermatoscope is $250. It's a little gizmo that has a magnifying glass and the round button there, and a light so that you can see down onto the skin. Or you get the fancy one at the bottom, and that's $18,000 or $20,000. Most of us don't have those, but we're using cheaper models. So what we're looking for are abnormalities of the capillaries. You may remember that blood leaves your chest and goes out an artery to your fingers and toes, makes a U-turn and comes back. So the U-turn is what we're looking at. On the upper left are little fine pink, reddish purple kind of picket fence appearance. And that's the normal. Other times they're just red dots. On the upper right, these are big. They're starting to swell up. And when they do that, often you can actually see the loop. On the normal capillaries, there is a loop there. You just can't see it. It's so fine. So when you get to the upper right, you start seeing large capillaries. And then in the lower left, you see not only dilated capillaries, but there are a lot of capillaries missing. So per millimeter across, there's a lot less capillaries. So dropout is the other thing. This is found in only 2 disorders, Scleroderma and dermatomyositis. It's a type of inflammatory muscle disease that has certain characteristic skin findings. Here we have pulmonary interstitial lung disease on the left. This is a chest x-ray. The central shadow is the heart, but there's a lot of fuzzy stuff in both lung fields near the bottom, and that's all the appearance of fibrosis. Starts casting a shadow as strands of fibrotic material. So this is a high-resolution CT, which is much more sensitive than a chest x-ray. And if we have any doubts about whether there's really sclerosis of the lung tissue or there's fluid in there, then we'll get a high-resolution CT. Normally, the lung field looks like a dark gray. So there's a lot of white stranding in both lungs. That's fibrosis. That's what we want to prevent. Then on the right side is an echocardiogram. What is shown there is a dilated right atrium, right ventricle, and a movement of the interventricular septum. These all suggest that the right side of the heart has gotten larger. In some people, the lungs, the arteries in the lung will start developing thick internal lighting, and it narrows the caliber of the tube. And if the heart can't get the blood into the lung easily, then it starts working harder. And it's a muscle, so pretty soon the right side of the heart starts pumping at a much higher pressure. This is an example of Raynaud's, two of the most common findings, white and purple. There are several relatively specific scleroderma-related antibodies. One is anti-centromere. Again, this picture that you see there is the immunofluorescent detection system. There's also anti-SCL70, an anti-PMSCL, which is polymyositis with scleroderma. That happens in about 5% of people with scleroderma, a true inflammatory muscle disease. RNP, and the most recent available one is anti-RNA polymerase III. Now, I'm going to talk about some of these antibodies in a few minutes. So now we come back to the criteria. So if whatever is going on, you add them up, the abnormal things or the things that bother you are added up. If the score is 9 or above, you have a 91% chance of having scleroderma. On the other hand, if you have scleroderma, you have a 92% chance of meeting these criteria, which in biology is a very good set of criteria. The next question is more important to me, at least at the beginning of the conversation. When does scleroderma begin? And I'll get into why that's important as I go along. So in the majority of people with scleroderma, there are 3 symptoms, complaints that are most common at the beginning of the disease. Swollen fingers is one. Polyarthralgia, that means I hurt in multiple joints, or polyarthritis. The doctor can actually feel swelling and other aspects that suggest this is a true arthritis. Finally, Raynaud's, whether it's got painful ulcers or not, it's Raynaud's. Okay, so here diagrammed is the definition of diffuse and limited. If someone is going to develop widespread skin thickening in the pattern on the right, or diffuse, they will have done so within the first 1 to 3 years, most of the time. So to make that diagnosis, we have to find thick skin on the upper arm, chest, belly, or anterior thigh. If you have on the central, you most likely are going to have it in your arms and fingers, maybe your face, and occasionally the legs. Limited never goes, the thickening never goes above elbows or knees and doesn't go down into the chest. Oops, sorry. So the reason to make this distinction, at least at this point, is that there are slight differences in the course of diffuse versus limited. Now, the terms limited and diffuse apply only to where it is on the skin. Now, early on, people may have diffuse, and over 10 years, they soften, and when somebody sees them for the first time, they look like they have limited because they don't have all the thick skin they used to. So the best time to measure this is 1 to 3 years, and that gives us the best chance of predicting the future. So the diffuse person, here again we're trying to time the onset. The diffuse person usually has a pretty good idea when it started because things are happening very fast. The skin is getting swollen, tight, and they're getting stiff. They hurt all over. They're losing the ability to make a fist and to grasp. Their skin itches terribly. And in some cases, I see finger marks from the scratching. Some may begin becoming short of breath. And fatigue is very common, and it's very draining, and some people need to take naps. Heartburn and trouble swallowing are distressing. And as my younger son would say, their quality of life sucks. So, to put this in perspective, when do people tend to wind up in a tertiary center like a university anywhere in the United States? Diffuse people tend to show up early because there's a lot going on. They want somebody to explain what the hell's going on. Limited folks, it kind of sneaks up on them. And eventually they may have a sore or they may have some other thing that they finally ask to see a specialist. They take some time because they don't have enough complications early to push them. But after a while, it accumulates, and they may ask for a referral. When you ask people with limited, when did it begin? Well, it's a little tougher. Some of them will remember about the time that Raynaud's began. And that may or may not be the same time that the skin starts getting thick. So I'll talk about that in a minute. So when you ask these folks, how long have you had scleroderma symptoms, they're often not sure, other than Raynaud's. Well, this presents a problem in designing clinical trials. So we've managed to change the definition of when it began to the following. The first symptom typical of scleroderma other than Raynaud's. So we discount Raynaud's as the beginning. Maybe, but for practical purposes in trials, we tend to use the definition I've given you here. Another tactic is to ask when the swelling of the fingers or the hands of the arm began. And again, some people, it sneaks up so slowly that when I show them that their skin is tight, well, I never knew that. So sometimes it gets challenging. So in summary to this question, when did it begin? Diffuse people, they're pretty good timing onset because a lot happens suddenly. So it's present in their mind from day one. And limited, it's a little different for the reasons I talked about. So it becomes up to us to make an educated guess. And this will be important. Timing of the onset allows us to get an idea of what happens at 1 year, 2 years, 3 years, 5, 10, so on. So we have to have something that we rely on as the beginning. So it could be arthritic complaints. A number of people get diagnosed with rheumatoid arthritis, and only later when the skin thickens does anybody say, oh, well, maybe this was scleroderma after all. They may be short of breath. That's dyspnea. Tendonitis. There's a fair amount of tendonitis and musculoskeletal involvement and pain. This is a particular kind where there's a scraping feeling, particularly over the wrists or the knees or the ankles. These folks may have rubs, is what they're called, friction, and they scrape. You can feel the scraping. Or they may have lung fibrosis that was picked up on a chest x-ray. Puffy fingers is a good one. Sores on the fingers, pretty good too. Heart failure, the heart just can't keep up with the demands, and so it just fails, and people wind up with edema of their ankles and sometimes fluid in their lung sacs. Or trouble swallowing or heartburn, and it's often one that requires a little more medicine than the average bear. So it may be taking 2 Prilosix a day, or Nexiums, or Protonix, or Acifex, or Dexilant. So how is my skin thickening going to change? Well, the physiology of what happens in the skin is on the left side, you see something that looks pretty normal in the diagram. We are particularly interested in the dermis. Now, if you take your fingers on one hand and pull the skin on the back of the hand on the other, you should get a fold. The fold consists mainly of this structure called dermis. The epithelium is very thin. If I blister from too much sun, epidermis comes off. The dermis is the main thing, and this is the organ that is invaded by collagen. So it gets thicker. It also can crowd out hair follicles and oil glands and sweat glands. So I've come to rely on cheese as a way to talk about skin. Normal skin is more like thin slices of Velveeta cheese. They're thin, they're wiggly, they're flexible. On the other hand, in scleroderma, with all this thickening in the dermis, it becomes inflexible, like a brick of cheese. If you try and bend the brick, it may suddenly pop open. And that's maybe what happens in people who have thick skin over a joint, finger, elbow. They try and do this, and there's an open spot. The skin has burst open. It can hurt, needless to say. There's a technique that Jerry Rodnan developed. He was a big-time investigator in Pittsburgh. He's credited with really getting the world interested in scleroderma. He was looking for a way to quantify skin. Skin is the largest organ in the body. Problem is, it's all over you like peanut butter. It's not in a location. It's not a kidney, it's not a liver, it's not a heart. It's all over you. So one way to do this, and several skin scoring methods have been tried, and they all kind of wind up with this one. You score it on a 0 to 3 in 17 body areas. So here you see a forearm, you see the back of a hand, and again you see the finger. And each time we give it a value of 0 to 3. And this is experience-based. Of all the people I've seen, I have some idea of what a 1 and a 2 and a 3 should be. Okay, so that's the fold on the back of the hand. This is a fancy drawing. You don't need them this fancy when you do it in the clinic, but this is a textbook. The advantage of this kind of pattern is that it not only tells you the total score, in other words, how severely is the skin thickened, but it also tells you the location. So you will notice that the upper arms have a check, 1, and the chest has a 1. There are other parts that have 1s and 2s, or 3s. But because there is chest involvement and upper arm, this patient has diffuse cutaneous scleroderma. Limited and diffuse are both systemic sclerosis. They're just slightly different clinical types. And if you add them up, the score is 25 on this example. Okay, so again, reinforcing the idea of what is limited and what is diffuse, because the courses of the two are going to be slightly different and in important ways. So here we have the skin score and disease duration plotted here. The pink or red line, it shows kind of a monotonous low level. Some people, there is a little bump at the beginning up, and then it kind of levels off at a lower score. So maybe there was an 8 or 10 at the beginning, and now it's a 4. On the other hand, the diffuse kind takes off like a train. Now, it may not take off at the very beginning. People may get puffy hands and some tightness on the back of their hands, and after 6 months to a year, suddenly it takes off. Marches up the arm, gets the face, belly, so on. So it's frightening. Eventually, it's going to plateau somewhere at around 1 to 3 years, and then it will start softening on its own. Not everybody softens, but most people will have some softening in this period. Okay, it turns out high skin scores, greater than 20, skin scoring system again is 0 to 51. Fortunately, I don't see many people with 40s or even high 30s because they really get bound up. The skin around the joints just clamps down and they have trouble moving, getting up, using their hands. They're also at risk of kidney failure. Renal crisis is something that is peculiar to scleroderma. It's the onset of kidney failure, and it's usually associated with new, fairly aggressive high blood pressure. So there's a big increase in the chance that somebody with high skin scores will have kidney crisis. Mortality is increased at 4 years. At the time of entry into this study, if you had a score greater than 20, you could have heart disease and you could have disability, meaning you can't use your hands for much. It's a questionnaire that's easy to fill out. And if the score is not too high, it suggests that there's really some difficulty with doing activities of daily living. The higher the score, the more handicapped they are. Next question. What kind of involvements inside do I have right now? So the history and the exam help a lot. So we find out what the kinds of symptoms and signs, and we'll put that in context with the time of onset. So in the lung, pulmonary function tests are easy. Most people don't like them because the technician is going to whip you verbally. It's going to be take a deep breath, now blow it out, come on, keep going, keep going, keep going. That's for vital capacity. So if they're shorter breath and they have abnormal lung function, then consider a chest high-resolution CT to get detail of what's going on in the lung. Kidney, monitoring the kidney is really reserved mainly for people with early diffuse skin disease. The very few people with limited who get kidney failure. And after 5 years, even those diffuse patients who might have been at risk, if they get through 5 years without it, makes it much less likely that it's going to occur. I'll talk more about that. Echocardiogram is a reasonable test, is a screening test for heart. Gastrointestinal tract, often it's symptoms. There is a questionnaire that is standardized that is available. It hits the high points, heartburn, sluggish stomach, small intestine problems, and large intestine problems. Easy to fill out. Now, depending on the symptoms, we may need to look down the gullet with an EGD, looking for bad reflux or damage to the esophagus or a stricture, narrowing at the bottom. Gastric emptying is a reasonable test. 50% of people with scleroderma have a delay. That's because the smooth muscle has slowed down. And the lactulose breath test is easy and picks up bacterial overgrowth. That's something the average person doesn't know anything about because the germs they have in their intestine are down in the colon, the bottom part. In scleroderma, because the motility is slowed, bacteria start marching up into the small intestine, and that can produce bloating, diarrhea, and so on. Okay, so I'm going to come back to these scleroderma-specific antibodies. So the first one is anti-centromere. That's the shorthand. Most of the folks who have scleroderma and have this have a mild form. It's a limited is the usual. Late, they can get calcium deposits. Yes, they do get digital ulcers, finger ulcers. And late, 10 plus years later, they may develop pulmonary artery hypertension. The next antibody is topoisomerase. It's a mouthful, so SCL70 is easier. These people most likely are going to have widespread or diffuse disease. Not everybody, but the majority. They are at risk of lung fibrosis. One thing I should add about centromere is it is unusual for people with centromere to get severe lung disease. So that's almost a protection. SCL70 puts you at a risk. And kidney failure, yes. There is a 15 to 20% risk. Now, at this point, everybody's thinking, oh, I'm going to go home and get a blood pressure cuff and watch out for this. Most of the people in this room are beyond the usual risk pattern. A couple may have widespread skin thickening or diffuse, but they're beyond 5 years, or they've come 3, 4, or 5 and haven't had it, so it makes it much less likely it's going to occur. So RNA polymerase III is the newest that adds something to our diagnostic capabilities. They tend to be people with widespread skin thickening. They don't get much pulmonary fibrosis. Their organ of damage is the kidney. They are at 25, 30% risk of developing renal crisis. Okay, so what are the probabilities that I will develop internal involvements over time? Okay, again, we'll go to this diffuse and limited pattern. There are some similarities, but the differences are important. So what is the likely course in diffuse? Okay, this histogram tells you when there's a patient newly having renal problems, kidney problems. So 10% have it in the first year, 5 additional percent the next year, 4%, 2%, 1%. Excuse me. Asthma. So in total, there's 22%. But you notice the slope. The big action begins early. Same in the lung. The first year is the biggest time of impact or the development of new lung involvement. And as you go along through 5 years, it declines. So that if you don't have it by 5 years, it's unlikely you will ever develop it. New heart involvement. Again, it's not quite as pronounced, but most of the trouble begins in the beginning, and as you go through 5 years, there's a lot less risk. And the GI tract is very similar. Most of the action occurs here in the first 2 years. It can be heartburn, it can be bloating, it can be nausea. I can't eat very much, I'm constipated. So all that fits into this rubric. So at the end of 5 years, we don't see new involvements pop up. Most of them have popped up. And this is the summation. All the curves look kind of alike. The action happens early. And when you get to 5 years, it's much less likely that new involvement will ever occur. Okay, so what is the risk? Renal crisis is 80% will have developed renal crisis within 5 years of scleroderma onset. That leaves another 20% scattered over 20 years. So once you hit 5 years, the risk has gone way down. The biggest decline in lung function occurs in the first 4 to 6 years. And I'll show you more in a minute. But that's the timing that we need to be picking up loss of lung function, because there are things that we can do to treat that. Heart and GI involvement, most of the new onsets, as I showed in the diagrams, will have occurred within 5 years. Now, unfortunately, some people get a lot of organ dysfunction. And the definitions of severe are that the vital capacity drops below 50%, renal crisis or kidney failure with or without high blood pressure. Heart is a large collection of fluid around the heart sac, or congestive heart failure, or the need to start a medicine to control the rhythm of your heart. GI tract, the really bad things are malabsorption. People lose weight, often have diarrhea and constipation, alternating. Repeated episodes of what looks like obstruction that comes and goes. Folks get swollen bellies. I mean, it just physically blows up. They may have diarrhea, then it may be constipation. They are afraid to eat because it triggers this whole obstructive kind of phenomenon, or the need to be getting home total parenteral nutrition. So here we see blue blocks and red blocks. So the kidney and the heart are almost always in the diffuse category if it's going to happen at all. The lung, unfortunately, it's about the same in the diffuse and the limited. And again, you have to remember, all of this is early stuff. GI tract is probably about the same in both. So to graph it, 5 years is kind of a watershed. 80% of those that are going to have kidney failure will have had it by 5 years. We talked about that a minute ago. So the next one is 70% of heart disease meeting that definition will already have occurred at 5 years. Lung at 64, GI at 60%. So only the people who wind up with the definition of severe heart, lung, kidney, GI are on this slide. And again, it shows that these things happen early. Limited is a little different. They still are at risk of the pulmonary fibrosis, and we need to pay attention so that it doesn't get so bad that people are going to need oxygen and stuff like that. In one of the studies, we were able to show that the course of pulmonary fibrosis and limited and diffuse were essentially the same entity, and that they do respond to Cytoxan. On the other hand, the benefits are there's low risk of kidney and low risk of cardiac or heart involvement. And the GI involvement is very similar in diffuse and scleroderma. Diffuse scleroderma. The damage to the GI tract, if it's going to occur, generally happens in the first few years. And the symptoms may not really pop up for 5 or 10 years later, but the injury happened early. And what's happening inside you is kind of a result of old injury. Doesn't mean that scleroderma has suddenly flared up. Okay, so let's look at the course. 40% of people with either form, limited or diffuse, are at risk of some loss of lung function and fibrosis. 13%, unfortunately, have a severe amount. That's vital capacity less than 50%. That's the test again. Take a deep breath, blow it out, keep blowing, keep blowing, keep blowing. So the question, once we had the answer, it was obvious, came about 20 years ago. Virginia Steen and Tom Metzger have had a data bank that now includes at least 3,000 patients. Some of them followed for 20 or 30 years. And what Virginia did was find the people who had severe restriction, in other words, vital capacity less than 50%. Then she went back in the records to see when these folks lost it. And if you look at the first bar, 32% of remaining lung function was lost each year for 2 years. That's a big wallop. 3 and 4 years, it was about 12%, and by the time you got to 5 and 6%, it was 1 or 2% change per year. Some older studies show that by the time people get to 8 or 10 years in scleroderma, their lung function really doesn't change much. So again, all the action happens early. And unfortunately, how much damage there is does give us some idea of how long people are going to live. There's no way to predict in a given individual who's going to die, but if you have severe lung disease, it puts you at some risk. Okay, here's the skin diagram again, and now I'm going to put on when organ involvements tend to occur. So we'll start with the limited. Raynaud's and finger ulcers often are very early. Trouble with the esophagus, people feel sticking, or they have heartburn, and interstitial lung disease or pulmonary fibrosis. Then things seem to coast along pretty nicely, and a few people will get malabsorption, lose weight, may need some special GI care, or pulmonary hypertension. Those with diffuse have a lot more going on early. These are the folks that may have joint contractures, their skin around their elbows, shoulders, knees gets so tight they can't move them properly. They may have these characteristic tendon rubs, scraping on the tendon, may have weakness in the muscle, interstitial lung disease, pulmonary fibrosis, in other words, pulmonary hypertension, heart disease, and renal crisis. And again, you notice it's early, and it's usually in the upswing. By the time things start down in the score, skin score, new internal involvements get less and less frequent. So once we get people to start softening, generally that's a good sign. So what are the recommendations for early surveillance? Lung. We know the problem is most likely to occur early, so we do lung function tests every 6 months for 5 years. If anywhere along the line people start complaining of shortness of breath, or if the vital capacity has dropped below 75%, we do a chest, high-resolution CT, and an echo to look at heart and lung. Heart, again, heart is usually going to be in diffuse. So those folks, particularly early, we'll do an echocardiogram, and if they become dyspneic, we may repeat the echocardiogram again and pulmonary function tests. But routine screening would be once a year for 5 years. Renal, again, is primarily in people with early diffuse. Have them check blood pressure 3 times a week. They can do it at home, or if they have a drugstore where they can sit down and have it taken, that's fine. Need to check it 3 times a week. If the blood pressure rises over 140 over 90, particularly if they've had a lowish blood pressure normally, repeat the blood pressure in 12 hours. If it's still up, you need to call a doc and get on an ACE inhibitor. There are a lot of them. The term ACE inhibitor is an umbrella for 10 or 12 different medicines. Captopril, Vasotec, Altase, Monopril, Acupril are some of the names. So here are the 5 questions again. Do I have scleroderma? When did it begin? What's the course of skin thickening likely to be? What internal involvements can you see now? And what are my chances that I'll get trouble inside? And we've answered them. We've addressed the diagnosis, how to determine when it began, how to determine skin thickness and what its likely course is over time. We've addressed how to determine involvements inside presently and to predict the probability of future. Now, brief comments about some therapies. The study that's referenced here is now 5 years old, and we're about to revise the recommendations for treating scleroderma. A group of young investigators is charged with rounding up all the literature on how to treat this or this or this. Then we as a committee get together, and if they are randomized controlled trials, that's good evidence that it works. If it's all expert opinion, that's kind of wobbly evidence. So in Raynaud's phenomenon, there's pretty good evidence that some medicines work. Nifedipine is worldwide. We have it here. Iloprost is now in Europe only. We did a study in the United States of Iloprost, and it does help ulcers and Raynaud's. It's an intravenous medication. The company did not push on, did not get approval, and it died. Europe has Iloprost, and they use it regularly, particularly in people who get ulcers or dark fingers. Digital ulcers, intravenous iloprost, again, is European. We're starting to get some permission from drug companies to use another one that looks like it, and that's called epoprostenol or Flolan. Prevention, bosentan costs about $75,000 or more per year. It can, or it's been shown to reduce the onset of new ulcers by 50%, but it requires that people have multiple ulcers. So if you have 4 or more ulcers at a time, this drug might help. Otherwise, we're wasting money. Lung disease or pulmonary fibrosis, cyclophosphamide is considered a useful drug. We're looking to see whether another medicine called Celcept will work as well. Pulmonary artery hypertension, in 2009, these are the ones that had pretty good evidence that they work. There have been a couple since. So there are now about 8 or 9 different medicines that can be used. So bosentan, Cetaxetin is not available in the United States. Sildenafil is Revatio or Viagra, and epoprostenol is an intravenous called Flolan. Methotrexate for early diffuse scleroderma. Not all rheumatologists or sclerodermatologists think so, but several of us think the evidence is pretty clear that it can help soften faster than nature would on its own. Okay, all of that has scientific evidence to say it works. Now we're getting into places where it's expert opinion. Renal crisis, the treatment of choice is ACE inhibitors. There will never be a controlled trial to find out whether these work. It's like penicillin. You had pneumonia, you got penicillin, you got well. An attempt was made in 1980 and 81 when captopril came out to try and compare the effect of captopril to another antihypertensive. The investigators abandoned the trial when they had only 2 patients in after 2 years. It was one of these black and white situations where everybody agrees they work. There's some risk of taking cortisone medicines, prednisone, Medrol, if you have early diffuse scleroderma. It may trigger a renal crisis episode. GI tract, this is a real swamp as investigators. There's nothing that has been done in a systematic way to know whether any of this stuff works. But we have a pretty good idea that proton pump inhibitors help control GERD. I mean, you just take care of people and it works. They're prokinetics for the management of intestinal problems or stomach. The one we have is metoclopramide or Reglan. There are a couple in Canada that we can get. One's called domperidone. There's no vintage year. It's just the tablet. And rotating antibiotics for malabsorption syndromes. And on that note, my time has expired. So we're talking about the Nailfolds.
Yeah, so when you said you had the Nailfold, it was either one of 2 things. Is that 90% of the time? You said it was either...
99.9%.
Okay, and say those 2 things again? It was either...
dermatomyositis. It's a muscle disease that has characteristic skin findings that are totally different than scleroderma. That's one. In this room, it's largely going to be systemic sclerosis or scleroderma.
And most doctors agree with that? And most doctors agree with that?
Yeah, I think so.
Okay.
Some centers who can afford the $18,000 to $20,000 gizmos have shown fairly conclusively it's pretty much related or isolated to those 2 diseases, and there is a change over time in what happens.
And how about with morphia or morpha?
Usually morphia has no Nailfold capillary changes.
Okay.
It's a skin disease, primarily. Yes, ma'am.
Antibody tests should we have?
Uh-huh.
Like, I've been told there's certain specific antibody tests that you should have, and I haven't had all of them, and when do you get them?
How long have you had? You have scleroderma, I assume.
I've been diagnosed 7 months ago.
About a month ago.
7.
Oh, 7 months. Well, you're still pretty early. There should be on the handout a list of the tests. Not sure which slide. But it talks about the commercially available ones. And since it's written down, it's easier to have you look at that than for me to tell you all these fancy big words. It's on page 4, bottom left hand. Specific scleroderma
Yes.
related antibodies?
Yes.
Okay, that's what you need to look into. There are about 5 of them.
And are these done at the very beginning and only when you're showing symptoms?
Tell me it again.
Are these tests given at the very beginning or only
Yeah,
when you show
I think
symptoms?
it's reasonable the first visit where somebody thinks you really have scleroderma, it's worth getting them. There's some evidence to suggest that this artificial division that we've made between limited and diffuse is not nearly as good as finding out what the autoantibody is, because the autoantibody is heavily linked to certain things, and they're different things depending on which antibody you have. That hasn't happened in reality, but I can see it happening in 5 to 10 years, that we will shift the paradigm. But these are the ones to get, and it does give us a clue what to expect. Not that you have all that stuff, but at least we'll know what to look for.